Good afternoon, everybody, and thank you for joining us for this Managing Your Migraine event on drug treatments for migraines. You have all been entered on mute, so if I could please ask you all just to remain on mute, because it can be quite distracting if we can hear people having their lunch and chewing on the crisps and that sort of thing. There'll be time for questions at the end, so if people have any questions throughout, please just put your question in the chat box, and my colleague Steph will be reading those out after Thomas's presentation. It is quite a popular event, so apologies if we don't get through all of the questions. All of our services are here if we don't get to your question, so give us a call on the helpline or drop us an email and we will try our best to help you. So apologies if you do ask the question today and we don't get to it. Please note that the session's being recorded. And with that, I will say a really big thank you to Dr Thomas Peukert from Royal Victoria Hospital in Belfast. And I will hand over to him and see you for some question and answers. Thank you, Thomas.
Yes, thank you very much, Debbie, for inviting me here to speak today. It's an honor to do this. I hope you can all hear me. I was asked to talk about managing migraine, and I was asked to talk about drug treatments. And although that, of course, extremely important, we in Belfast believe that obviously it's not all about drug treatment. It also has a lot to do with lifestyle changes. And we always make sure patients know about these. But this talk is about drug treatment. I talk a bit about the service in Belfast. So I'm a consultant neurologist in Belfast, and my special interest is headache and acute neurology. So I will see a lot of headache patients in the ED department. And we have a team in Belfast of 2 physiotherapists, 1 nurse, and 1 psychologist in the headache team. So it's a bit unique to have a psychologist and so much physiotherapists, but they're all trained in giving all these treatments. They're all injectors and prescribers. So it's a new team, and we are just evolving our service. So I just go ahead. What I'm going to talk today about is a bit the background, the agendas. I talk a bit about background of medications treatment in headache. Then I talk about acute management of migraine. What are you going to do when you get an acute attack? Then I talk a bit about migraine preventer. And then talk about newer treatments. And I know people here in this meeting will be from all over the UK, and treatments are very different in England, Scotland, Wales, and Northern Ireland. Depending where you're living, you maybe have different access to different kind of treatments. So I will talk a bit about this. Now, talk about migraine treatment in the past. In the past, actually, it wasn't migraine, it was more headache treatment. So in the past, everybody with a headache was treated the same, independent if it was a migraine or a headache due to brain bleed or a headache due to cluster headache. There was no differentiation. So it was really headache treatment in the past. And this guy, his name is Areteus, he lived about 200 in the 2nd century, and he believed in bloodletting for migraine treatment. So what he did at this stage, he did small incisions on the veins and did drain some blood. And that, if this didn't help, he did incisions in the forehead and drained blood. And if this didn't work, he used a goose feather and pushed it up the nostril and scratched on the base of the skull to cause some bleeding there. And believe it or not, this was going on up to the 17th century in Holland, where they continued to do bloodletting. And it's important to know, it sounds all very ridiculous, but as I told you early on, this is not a migraine, it's a headache treatment. So if somebody, for example, have a headache due to high blood pressure, then this might be a cure or might be a treatment option. So you just drain a pint of blood, the blood pressure goes down, and the headache might settle. So I'm sure in some patients, he had success with this. Later on, what they did was cupping and blistering. So they put some glass tubes over the forehead and over the temple, and that caused some blistering of the skin. And it was felt that this was a good treatment for migraine. Then they used more invasive procedures. So they opened the skull quite often at the beginning up to the muscles, later up to the bone, and at the end they also removed the bone up to the brain. And they thought they take the stone of madness out of the head. And therefore they thought. And again, there was one prescription of someone who found a worm in the brain. And they found that the worm is causing migraine. Retrospectively, this patient possibly has an epidural bleed and they remove the blood clot. So again, this is a treatment for some patients maybe have a brain bleed. That's what the neurosurgeons do now. They just remove the blood clot, and that can help some patients. I don't know if you can see the whole picture. I only can see all your faces on the right side. But on the right is a woman who has a book on her head. I don't know why this is the case. I'm not sure if you can see the whole screen or not. And then later on, what they used dead molds. They did bend dead molds around the patient's head. That was what they did in Europe. What they did in Egypt, they used dead crocodiles instead. So this might help headache. And then electricity was invented. So they used something called the hydroelectric bath. This was done by a guy called Rudolf Lewandowski. He put patients in a bath. They developed a special machine, and patients got electric shocks. And again, this sounds ridiculous, but we do know that we are using kind of electric treatment like brain stimulation for cluster headaches, like vagal nerve stimulation, supraorbital nerve stimulation. And in other parts of the world, before the electricity was invented, they used special fish that discharge electricity, like the electric eel, who can discharge up to 600 volt. And they use this fish on the forehead to treat headaches. So headache has a long history of treatment, very different. And I will talk mostly about the treatment now. Now you asked me to talk about migraine and medication. Now, how many migraine drugs are there? This is Alexander Mauskop, and he is a director of the New York Headache Center. And he has a WhatsApp group, the New York Headache blog, and he has there he describes 100 migraine drugs. So he's describing his blog 100 different drugs that you can use for migraine. So I won't be able to talk about all of them, but you can follow him on Twitter, and then you get, this is, for example, on the right side is a pyramid blog. It's not a lot of, well, some information, but you can click on links, and then you get all the background, you get all the research background. So it's sometimes quite useful. So there are a lot of drugs. I can't talk about all of them. So what I am going to do, I talk about acute management and about preventer. And it's important for patients to understand the difference between this, because quite often it's getting mixed up on my patients that I see in Belfast. So acute medications means you realize you are getting a migraine and you take an acute tablet as soon as possible to really stop the headache completely. And you should take it very early, ideally, it's to shorten or stop the attack. Preventers are tablets you take every day, independent if you have a headache or not, and this will reduce the severity and the frequency of headaches. So with a preventer, you usually won't be able to stop migraine completely. I have very few patients that I give a preventer and they have no more migraine at all, but you can reduce the frequency and the severity. You have to take, all migraine preventers are very similar. You have to start a low dose, you increase it to the highest tolerated dose, then you give it for 6 to 8 weeks, a migraine preventer. NICE actually recommends up to 12 weeks before you decide the preventer doesn't work. If the preventer doesn't work, you stop it, because you don't want to take medications long-term that has no benefit. And then you can try the next migraine preventer. If a migraine preventer works, you continue on the migraine preventer for 6 to 12 months. And when you feel, well, I'm at a good stage, stress level is low, it's a good time for me to reduce and hopefully stop it, then you should do that. Again, even if the preventer works, you should try to stop it. Maybe you're able to stop, but maybe you get away with a lower dose. So all migraine preventers should have the tendency to be stopped as well. Now I talk first about the acute management of migraine. So acute management, there's a leaflet here on the right side. That is from the Migraine Trust, and there's a lot of information on the Migraine Trust website. There's a leaflet for patients, so I won't be able to tell you everything what you find on the website. So it would be very useful if you read things up there as well. There's so much information there. So that's just a few principles for managing acute migraines. So as I told you earlier on, you should take the medication as early as possible. As soon you realize, oh, I think I'm getting a migraine, you can take an acute medication. Now, the problem sometimes as patients have is they say, well, we know we can't take these tablets every day, and I don't know if this headache now will develop in a really bad headache, so they wait sometimes a bit longer, and then it can be hard to control it. When the headache is too bad, it can be hard to control. Now, triptans are a bit different. When you have migraine with aura, so when you have something like visual aura, visual disturbances, pins and needles, then you should take the triptan after the aura when the headache comes on. The reason for this is that during an aura, you are getting vasoconstriction, you get tight blood vessels, while during the headache, you're getting vasodilatation, so wide blood vessels. And triptan is a vasoconstrictor, so it can make the aura worse. So ideally, you take the triptans after the aura when the headache comes on. Some patients I see who tell me, well, I take the triptan as soon as I feel the aura is coming on and it helps, but I don't stop them from doing this. But ideally, you should wait till the aura is over and wait for the headache starting to take the triptan. Then you shouldn't take all these medications more than 8 days per month. And that's because there is a risk of developing medication overuse headache. It depends a bit on the preventers. For example, paracetamol, you possibly can take 15 days per month. But for example, triptans or codeine, you definitely shouldn't take more than 8 days per month. And you need to be off contraindications. So the problem with these medications is a lot of them you can buy over the counter. You can buy on the petrol station. Now, this is not unique in the UK and in America. But I'm now from Germany, for example. In most European countries, you won't be able to buy paracetamol in the petrol station. You have to go to a pharmacy. And I think the problem is that when you buy things over the counter, just besides the Smarties, the sweets, you think there's no harm on these medications. And I have one patient who took paracetamol, a young female patient, paracetamol for toothache, and she took too many of them, and she needed a liver transplant after this. So don't underestimate how severe these medications can be when you take them too often. So be aware of the contraindications. So this is an overview of the acute medications. In general, you can say there are 3 different groups of acute medications. You have simple painkillers, you have antiemetics, which means medication that were designed to treat nausea and vomiting, and you have the triptan. These are the 3 groups of acute medications. So there's paracetamol. Most doctors will tell you paracetamol doesn't really work a lot for migraine. If it works for you, it's great, but don't take it every day. Try it 3 times. If it doesn't work, then forget about it and try something stronger. And then you have non-steroidals like Brufen, Naproxen, Voltarol, aspirin. Most of them you can buy over the counter as well. So there are some contraindications again. So for example, when you have asthma, you can't take them. When you have heart problems, angina, it can be a problem. If you have stomach ulcers or gastritis, you can take non-steroidals. You have to make sure you eat something with these medications. And you have the high-dose aspirin. So aspirin is a really high dose we would give for migraine. So when you have, for example, you take aspirin because as a preventer for a stroke, you take 75 milligrams. For migraine, you give 900 milligrams. So I give a lot of aspirin, high dose. But again, you have to be careful and tell the patient to eat something with this, and you can't take it every day. It's also a tablet you can take up to 8 to 10 times per month, but not more often. Then you have the antiemetics. These are medications designed to treat nausea and vomiting. And there are 3 of them you can use for migraine. The dose is always 10 milligrams. And there are 2 reasons for these medications. Number 1 is a lot of migraine patients feel nauseated when they have a migraine. And the other reason is that when you have a migraine, your absorption in the stomach is reduced, and you don't absorb paracetamol, Brufen, naproxen very well. So the antiemetics can help you to regulate this and to improve the absorption and help you to absorb the simple painkillers. And then, well, you have to be careful with metoclopramide. That's the only thing I want to say. You have to be careful, although I give it a lot, because it can give you movement disorders. So especially on younger patients, so it can give you symptoms which look a bit like Parkinson's disease. So you have to be aware of this. So if you develop this, you have to stop it. And then you have the triptans. Now the triptans was the first drug that actually was designed to treat migraine. And years ago, I think it was when I was a medical student, they realized when you have a migraine attack, you have vasodilatation, so white blood vessels. So they decided to design a drug that constrict blood vessels, which was a triptan. And there are now 7 of them, and they're all written down alphabetical order. The most common used one is sumatriptan, because a lot of studies are done with this, and I use it quite a lot. The advantage of sumatriptan is also it's available in tablet form and in nasal spray and also as an injection, while most of the other triptans are only available in tablet form. I think zolmitriptan is nasal spray as well. These are vasoconstrictor, and the difference between the different triptans is if they're working fast or if they're long-acting. So that's a bit of a difference. If you fail on one triptan, you should try a second and a third triptan. You should try at least 3 triptans before you make a decision, well, triptans don't work. So these are the triptans, and they're used quite a lot. And obviously, we combine a lot of medications. So you can, for example, typical combination is you give aspirin 900 milligrams with metoclopramide 10 milligrams. You can buy it. It's called Migramax. It's already combined. And then you can add a triptan like sumatriptan on top of this. So you can bind them. You don't want to combine Brufen with naproxen and Voltarol. You should go ideally to different groups of migraine medications. And as I mentioned earlier on, paracetamol you can take maybe 10 to 15 times per month, but the triptans you only can take up to 6 times per month. That is really got a small pocket, box always of triptans. There is now a special slide about menstrual migraine. I have just one slide in there because menstrual migraine is unusual. About 1 out of 10 women would say, I'm getting a migraine only around my cycle. But a lot of women also would say, well, I get it quite often, but more around my cycle. So sometimes patients take only sometimes something around the period. And the interesting thing is that is then you do really migraine prevention because you start this treatment 2 days before you expect the period, so before you expect the headache, you start the treatment, but you're using acute medications. You don't use the preventer. So you use naproxen or 2 of the long-acting triptans, and you take them 2 days before you expect a period, up to 3 days after the first day of the period, and you take it regular to control the headache, to prevent the headache, and you're using acute medications. But then you have to be careful not to use it too often between the period, because otherwise you end up with a medication overuse headache. So these are ways to manage menstrual migraine. And then we talk about migraine preventers. The migraine preventers are medications you try to give to prevent headaches. Again, there's a leaflet from the Migraine Trust. You can have a look. There's a lot of information there. So, and there's the idea not really to stop the headache completely. You don't manage this. And we have to be realistic about what to expect. You might be able to reduce either the severity of a headache or you are able to reduce the frequency of the headache, but you won't be able completely to stop the migraine. It's very unusual. NICE recommends that you should continue to prevent at least for 3 months, but I think it depends a bit. For example, candesartan, yes, candesartan, if you give up to 3 months, it takes a bit longer, but other medications like propranolol, if they don't respond after 2 months, I quite often stop and give something else. And NICE will say a good response is if you have a reduction of severity or of frequency of 50% of the migraine. Now, I think it's important to also talk about the severity reduction, because a lot of trials, when they look, for example, at Botox trial, they just look at the reduction in in frequency and not of severity. And that can be sometimes a bit confusing. So it's important that you have a headache diary and you write down how bad is the headache out of 10, and then you can see both the severity and the frequency reduced. And if there's nothing happening in 6 to 12 months, if it's working after 6 to 12 months, you should go and try to reduce them. So to give a migraine preventer, you need to have at least 4 migraine days per month. Now, some of you will say, well, I don't want to take a preventer for something. I have 4 days per month. And that's fair enough. When you can control these 4 days with acute medication, then I would prefer that. But some patients will tell you, well, I'm missing 1 day at work every week, and I tried all acute medications, triptan, nothing has helped, and I'm in the process of losing my job, then you can give a migraine preventer. So you need to have significant disability with the individual attack when you have 4 days, but you need at least 4 days before you get actually a migraine preventer. And 80% of patients will discontinue the preventers, and they discontinue either because they're working or because they're getting side effects. And the idea is also of a migraine preventer to reduce the frequency of acute medications. So a lot of patients at the beginning have a headache 3 times a month, then 5 times a month, and 10 times per month. So they increase their naproxen intake and their brufen intake, and suddenly, before they realize, they suddenly take 20 days per month, these medications. So it's important to start then a preventer at the right time to prevent to develop medication overuse headache. So how do you choose now? I mean, there's so many different migraine preventers, and when you come to us, we really have to make a decision, what do we give you? And the thing is that none of these tablet form as migraine preventers yet were designed actually to treat migraine. Lamictal, for example, was designed to treat epilepsy, candesartan for high blood pressure, amitriptyline to treat depression. So they were all designed for something else, and for that reason, they all have the potential to give you side effects. So you have to make a decision together with a patient, what should you do? Or should you maybe try the mole and put this around the head as an alternative? So how do you choose? So you look at the preference for the patient. For example, if the patient is really overweight, you maybe do not want to give amitriptyline because that can increase weight. Or if somebody is really underweight, you maybe don't want to give topiramate because this can drop the weight. So you have to think about these kind of things. You look at drug interactions. If somebody is already on antidepressant, you don't want to give amitriptyline because this can affect the heartbeat and it can give you an irregular heartbeat. It can be dangerous. You look at other comorbidities. If somebody has asthma, you can't give a beta blocker because it can make the asthma worse. It is available. I said early on, we all live in different parts of the UK, and some parts you can't get Botox, and some parts you can't get monoclonal antibodies. So you have to think about these things and how effective is this treatment. So there's, for example, riboflavin or magnesium. These are migraine preventers. They are not as effective, but there's much less side effects. So you have to think about these kind of things when you make a decision. So I can't talk about all of them. I said early on, there are about 100 or more. So I talk about common ones that we are using. So we talk about propranolol. There are the 4 big ones in oral form we're using. Propranolol, amitriptyline, candesartan, and topiramate. These are the 4 big oral medications. And then you have obviously Botox, talk about this, and you have the monoclonal antibodies. That's what I'm talking about. Now, in the past, before Botox and monoclonal antibodies were invented, you had no choice. You have to go from one to the next migraine preventer because there was no option. Now, after 3 or 4 preventers, you usually go to Botox or monoclonal antibodies. But I have patients who have tried 15 to 20 different migraine preventers without any benefit. And so now, hopefully, we don't try, like, for example, sodium valproate is a drug with a lot of side effects. I have maybe 1 patient on this. So you possibly try to avoid these medications now. So let's talk about the propranolol. The propranolol, the beta blocker, was designed to treat high blood pressure. I'm sure a few of them have tried it or are on it. And because it was designed to treat high blood pressure, it has the risk of reducing the blood pressure. And that means it can make you dizzy or lightheaded in the morning. You can't take it when you have asthma or when you have COPD. It also slows down your heart rate, so it can make you bradycard. So when your heart rate is below 50, I wouldn't increase it. And you usually start on 40 milligram twice a day, and you can increase up to 100 milligram twice a day. Now, if you have now a patient, for example, who tells you, well, I had asthma when I was a child, but I hadn't had asthma for 30 years, you maybe want to try the propranolol. So I'm not someone who would say, oh, you can't try it, but you maybe go then on a lower dose. You maybe try maybe 10 milligram twice a day first and see how it goes. So you can do it, but the doctor needs to be aware of this, and the patient needs to be aware to attend, to go to ED if the breathing is getting worse. So, and it usually can reduce the headache by 50%. 50% of patients will reduce it by 50%. So it's a very common, a very old, a lot of experienced blood pressure, doesn't have a lot of side effects long term. When you have patients who are on this long term, maybe they're 30 years when they were put on, and then maybe they're getting older, and then the blood pressure in general drops down quite often when they're getting older, then you have to be aware that sometimes these side effects develop over time. So let's be aware of this. Amitriptyline, that was designed to treat depression. And So you have to be careful if the patient is already on another antidepressant, because this can affect the heartbeat. You have to be careful in some kind of heart diseases. So you normally need an ECG before you start it and also before you increase it. Side effect, it can make you weight gain, it can make you tired, it can give you a dry mouth. Now, if a patient tells me, well, it works for my headache, but I'm feeling tired in the morning, I normally ask them, what time are you getting up in the morning? When the patient tells me I'm getting up at 7 o'clock, then we would recommend to take amitriptyline roughly at 7 o'clock at night. So you should take it roughly 12 hours before you're getting up. That's the main mistake patients are doing. They take the amitriptyline just before they go to bed at 10 or 11 o'clock, and then they're tired at 7 o'clock. So then just bring it forward and see how it goes. So you can start on 10 milligrams, and you can increase it every week by 10 milligrams, and the highest dose is 150 milligrams a day. Not a lot of patients will tolerate 150 milligrams per day. Other consultants will start on 25 milligrams. Some consultants will start on 5 milligrams. There's a bit of playing around there. And also can reduce headache days and frequency by 50%. But again, you have to take it for 6 to 8 weeks on the highest tolerated dose before you know. Candesartan, this is possibly one of the newer medications. It was used a lot in Scandinavia and America before it came to the UK. Is an angiotensin receptor blocker, which means it also was designed to treat high blood pressure. And again, it can drop the blood pressure, but it doesn't drop the blood pressure so much on patients that have borderline low blood pressure anyway. So propranolol will drop the blood pressure on these patients as well. Candesartan is a bit better tolerated there. It can give you renal failure, so possibly you should get your blood taken from time to time for kidney function, and you should not take it in pregnancy. And again, there are some consultants who will not give candesartan if the patient is not on appropriate contraception. And the benefits are similar to propranolol. Highest dose is 16 milligrams per day. And candesartan needs a bit longer. It needs up to 3 months really before you get the full benefit from it. And the fourth one, topiramate, is an anti-epileptic drug. And you start on 25 milligrams, you increase up to 100 milligrams twice a day, sometimes even higher. The problem with candesartan is you shouldn't get pregnant on the problem with topiramate is you shouldn't get pregnant on topiramate. But if you are on a high dose of topiramate, it can make the pill making fall, the contraception being fail. So you might get pregnant although you're on the pill. So be aware of this. So when you take a really high dose, over 100 milligrams twice a day, you have to be careful of taking topiramate. It is possibly the best migraine preventer out of these 4 in reducing headache days. But the problem is it's quite often not tolerated because it can give you depression, it can make you lose weight. Quite often you have young female patients who maybe plan a pregnancy, so not very well tolerated, but as soon as it is tolerated, it is a very, very good migraine preventer. And then I'm looking at the same time of my time, we have the Botox here. Now, Botox we give a lot of Botox in neurology for a long time. We gave a lot of Botox for dystonias, for movement disorders, for patients who are paralyzed. So in the past, it was given for spasticity. And we also gave it for something called blepharospasm, which is nervous eye blinking. The patient has nervous eye blinking. So these patients got injected Botox around the eye. And they realized then that the Botox helped for the eye blinking, but it also worked for the wrinkles. So then the cosmetic industry jumped in, and there was a lot of research done. And as you know, a lot of patients get now Botox for cosmetic reasons. And these patients then reported that it works for the wrinkles, but it also helped for the migraine. And then the neurologist stepped up and did the big trial, was a preempt trial performed that looked into data, how can Botox reduce a migraine, and it played around with a different injection point and different doses, and they came up with 31 injection points and 155 units given, and that seems to work for chronic migraine. And the preempt trial showed that Botox on average reduces migraine days by 8 days per month. But the control group got saline injected, so placebo, and in that group, the headache day reduced by 6 days per month. So it was just 2 days difference. But apparently 2 days are statistically significant. So Botox does work for chronic migraine. And when I say that, some patients have a great, much better benefits in 8 days, and some patients don't have any benefit at all. So the 8 days is the average. So every patient is very different. So we have quite a lot of patients on Botox in the Belfast Trust, and they're coming in every 3 months. They're getting it. We are getting 31 injections the first time. Second, after this, we sometimes give a few more injections. We do something called follow the pain guidance. We give the 31 plus additional injections, and we keep it going for a year ideally, and then we try to wean patients off. We go there maybe for 4 monthly or 5 monthly and 6 monthly, and then try to stop it. But quite often you can't stop it. Quite often the headache comes back again. You maybe have to go on and increase frequency again. Now these patients who get migraine for Botox for migraine reported that it helps their mood. And actually my understanding is that they look now if actually Botox can treat depression as well. Side effect of Botox is the thing to get injected tablet, the half-life time is short. Botox, the half-life time, well, it works for about 10 weeks. So the patient needs to be aware that the side effects then are long-standing, but you don't get systemic side effects like on the tablets. You don't get the tiredness, depression, low blood pressure. So all these kind of things you don't get. The Botox is better tolerated than these 4 oral migraine preventers I told you earlier about. And then you have the monoclonal antibodies. And I don't know who of you is on it. At the moment, there are 4. There are 3 NICE approved, which are injections. There is Erenumab. That was the first one approved. That was approved actually before COVID, and we started patients on Erenumab before COVID. And then when COVID came, all this was stopped. And then you have 2 other ones, Fremanezumab and Galcanezumab. So these are the 3 monoclonal antibodies where the patient can inject themselves. There's a difference between Erenumab and the other 2 because they're working slightly different. Erenumab binds on the CGRP receptor side, while the other 2 binds on the CGRP peptide. So they did find out that when you have migraine, your CGRP level is increased in your blood. So they designed a drug. This is the first drug designed actually as a preventer to treat migraine. They designed a drug to reduce CGRP, and either by binding on the receptor side or binding on the peptide. You can give us, the dose is slightly different, obviously. The Erenumab, you can give 70 or 140 milligrams, although NICE actually said only 140 milligrams. The Fremanezumab, you can give either monthly or you can give it 3 monthly. But at the end of the day, the way it works is, the way we do it in Belfast is patients coming in, they're getting the first injection with us, and then they're getting the injections for home, and they inject themselves every 4 weeks at home. In other parts, the first 3 injections will be given in hospitals. There are different ways to do it. But after 3 months, you look and see was there any benefit. If there's no benefit, you stop it. And again, there is the problem with how do you measure benefit. And we do a lot of lifestyle, advice, and we also collect data like the HIT6 score and the MSQ score, the quality of life data. We look at headache days and headache severity. Now, sometimes NICE recommend on some of these drugs, well, you need to reduce your headache days by 30%. Now, the problem is when, for example, somebody has every day a headache, 10 out of 10. And you give them this drug, and actually I have a headache, I have a patient like this, he has every day headache 10 out of 10, he is now on Galcanezumab, his headache is now 1 out of 10, still every day. But he said the first time he was able to read a book for 10 years, he is able to work, he's playing with his children, so his life quality has severely improved. But he has still everyday headache 1 out of 10, following NICE, we should stop it because he still has everyday headache. So sometimes these things don't make sense. And we sometimes have to cut corners there. So in general, the idea is that about 40% of patients have a reduction of 50% of the headache days. And this is now a new drug. There's also a CGRP receptor antibody. And that is now NICE approved just the last 2 months, maybe, I'm not sure, not very long. I have no experience with this. The difference is that these patients are coming in and they're getting it infused. There's an infusion and they get every 3 months. There's an IV drug. And I am not too sure yet. As I told you, I have no experience. The drug company told us that the advantage is it works straight away. From day one, it works, which is good. But patients have to come in. But some patients don't like to inject themselves. So in Belfast, we have a problem because we are giving patients Botox who live far away. They have to drive 2 hours and drive back 2 hours. So it might be easier for patients sometimes to inject themselves. But these patients here, they wouldn't like to come in for a drip, but at least they only have to do it every 3 months. So I have no experience yet. I don't know where it's available. It's NICE approved, so it should be available in England and in Wales, I would guess. It's in Northern Ireland. We don't really follow NICE, so we don't have any patient yet, but hopefully in the future. And then there are other drugs coming out. For example, coming out the G pumps. I'm not sure if you heard of them. These are also CGRP receptor antibodies, and these are in tablet form. These are the same drug, but you take them as a tablet. And my understanding was that one of these, there's 3 different ones, one of these tried to get NICE approval, but was rejected. But my understanding is that hopefully end of this year, some of these will be NICE approved. So these are tablet form, these are smaller molecules, and I wasn't involved in anything of the research, but my understanding is that they were designed to treat acute headache, actually. So they were designed to work like triptans, that as soon as you get a headache, you take 1 tablet to shorten this headache. And the advantage of them was that they are not as vasoconstricting as sumatriptan. So the triptan problem is when somebody has ischemic heart disease or stroke, you shouldn't give a triptan. While with the new G pumps, they are not vasoconstrictor. They prevent the blood vessels from dilate, but they don't vasoconstrict. For that reason, they should be more safe in patients with stroke and ischemic heart disease. So they were designed to treat acute migraine, but then they realized that you possibly do not develop a medication overuse headache. And for that reason, you might be able to give them as a preventer and take them every day because you don't run the risk of getting medication overuse. So there's really kind of the last slide. So when you make a diagnosis, when you give medication, the first thing is you have to make sure the diagnosis is correct. So in every single patient I'm seeing, I go through the history again. Because headache is different than if I do an MS clinic. If I do an MS clinic, I know the patient has MS. I saw it on the MRI scan. You send blood for lumbar spinal fluid for confirmation. This migraine or headache changes quite often. Patients come in, they sound like a migraine. 4 weeks later, they come in and they sound like a cluster or like cervicogenic headache. So I always go every single clinic again through the basics of the history to confirm the diagnosis. Then you have to get the realistic expectations to patient. Don't expect I'm give you a propranolol and you will be pain-free for the rest of your life. It doesn't work. When you have migraine, you have a lifelong condition and you have to be realistic. Consider non-pharmacological measures. So I told you early on, medication are important, but lifestyle is important as well. So if I would tell you there is a drug that you can take and that will reduce your headache day by 1/3, it will reduce your risk of ischemic heart disease, out of diabetes, reduce the risk of bowel cancer, breast cancer, and many more benefits. It has no side effects. It is free. You all would take this drug. When I tell you that this drug is exercise, then you don't want to take this drug anymore because that is people prefer to take a tablet. But exercise is extremely important, and other lifestyle changes are really important. But it's not all about tablets. Use the right drug. Make sure you take the right migraine preventer and the right acute medication to the right person. Use effective dose. Quite often we see patients that come in and said, oh, I failed on amitriptyline 10 milligrams, but they were never increased. And I think that is a problem sometimes with GPs. They are too busy at the moment. We quite often try to have a good plan for patient. So we send a GP letter where we tell them, okay, start amitriptyline 10 milligrams, increase every week by 10 milligrams until patient is on whatever 70 milligrams. And we copy the patient in that the patient knows exactly what the plan is, because then the patient should put pressure on the GP to get the right dose. So a lot of patients fail on just doses that didn't work. Treat early when the pain is mild, told you early on, especially acute medications. Look at other symptoms. Look at nausea, vomiting. Choose appropriate route of delivery. Somebody is vomiting. You maybe want to think to give more nasal spray, or maybe you have to inject yourself. Avoid medication overuse, extremely important. and use prophylactic treatments appropriately. And I mean, headache has changed so much. Headache is really, really interesting now at the moment to be in headache management, because there's so many new treatments coming out and so many new treatments came out over the last 10 years or so. So it's really, really evolving a lot. And I compared with MS when I started in neurology, there was nearly no MS treatment. And over the last 10 years, so many new MS treatments coming out. I think that's the way headache is heading now. This is very good. Let's look at the next slide. You can see what has changed over the last 13 years. So the left side, if I would have seen you in the headache clinic 1895, I would have put a pot over your head and smashed with a hammer over your head. And now on the right side, well, I doubt that is definitely not Belfast. I doubt it is the NHS. It's possibly a private practice somewhere. But you can see how headache has changed. Now we give infusion drugs for migraine. In the past, they hit you with a hammer. Here we go. So, and that is really, so if you have any question, I have no idea what the time is. Oh, actually not bad.
Thank you so much, Thomas. That was really, really interesting. I hope you all found that really helpful. I can see that the chat's been going mad throughout. So we will, I'll pass over to Steph and she will ask some questions. But again, if we don't get to your question, we're really sorry, but please do use our services. So Steph, I'll pass over to you.
Yep, great. So we've had a few queries actually regarding the monoclonal antibodies and people that have been on these for 6 months plus where they're not working. So they're relying on taking triptans every day. But now they're being told about medication overuse and having to stop the triptans, and just about how they can cope with that, and also how to reduce the resulting migraine attacks if the monoclonal antibody isn't working.
Yeah, when the monoclonal, at the moment, monoclonal antibodies in Belfast is the end of the line at the moment, so the injectable. But you can move between the monoclonal antibodies because they're working slightly different. So when you failed on galcalizumab, then maybe you should try erenumab. So I have a few patients who failed on erenumab and I moved them to another monoclonal antibodies. The problem is sometimes you don't know if they are working, because you say, well, I think the headache is better, but I would have expected more. And that is sometimes tricky, because here in the UK, you don't combine things. In America, they give a lot of Botox and monoclonal antibodies together. Well, I don't know how it is in England. In Northern Ireland, we don't. We give either Botox or monoclonal antibodies. But I do know in America, they combine this a lot, and maybe that will change here as well. If a monoclonal antibody, well, is not working at all, then you should stop it. And you could try a different one. And maybe in the future, you can try a Gepant. Regarding the triptans, well, you see that we always say don't take more than 6 or 8 per month. Now, we obviously also treat cluster headache patients. Cluster headache patients have severe headache for a few weeks, and they really overdose themselves in triptans. And we are kind of keeping a close eye on this and accepting it in a way, because we know they do that maybe for 2 months, and then the cluster goes away and they don't take triptans at all. So you really develop an overuse headache when you use medications for longer than 3 months every day, more often 10 days per month. So when you use too much triptans, you have to be aware when you stop the triptan, you get a rebound headache, quite severe. So you will be for 3 or 4 days quite unwell. And where I'm from in Germany and also in America, quite often these patients are getting admitted to hospital for medication withdrawal. I tried it once in the Belfast Trust to admit a patient for medication withdrawal, but you won't get a bed for this.
Okay, that's really useful. Thank you. Someone else has been asking about the long-term effects of taking preventive medication like propranolol and nortriptyline. Are there any long-term implications?
Well, you see the older fashioned medications, amitriptyline, propranolol, they are so long on the market. I am not aware of too many long-term medications. You always have the risk of getting used to medication, either really addicted to it or psychologically addicted to it. The problem with the newer drugs is obviously you don't know what happens 20 years down the line. They are not that long there. You don't have long-term data really. You have only data for a few years, but you know, that's always a problem when you get new medications. You don't know what happens 20 or 30 or 40 years down the line. But the amitriptyline and propranolol, there are not really severe long-term effects, apart from when you are getting, maybe, as I told you, the blood pressure maybe change over time when you're getting older, or maybe get another medication added to this. So I always review all medications of all my patients, whatever they're taking, to make sure there are no contraindications.
Okay, lovely, thank you. I think in the presentation you mentioned about taking the triptans after the aura stage for the head pain. Someone has said that they actually get the head pain and the aura together, but if they wait, then the head pains progress too far for the triptan to help. Do they take it at the start with both, or?
So ideally you should take the triptan when the headache starts, and not with the aura. But as I thought, some patients didn't know that, and take it before the aura and said it works. So I don't stop them doing it this way. But ideally, when you start a triptan, you should ideally take it at the beginning of the headache and not the aura.
Okay, but the headache could be whilst the aura is still present.
It is, yes. It is. Some people get the aura after the headache. Those people are different. It's so much overlapping. So it's a bit of playing around, but you need to be aware that, and it's always textbook-wise, you say you can get vasoconstriction during the aura and vasodilatation during the headache. But when you have both together, what do you have? I don't know. So sometimes you have to try a bit around, make patient aware, try to avoid the aura, but try things and whatever works best for you.
Okay. All right, lovely, perfect. And there's also been a question just about what lifestyle changes are most effective for migraine.
The most effective lifestyle is exercise. Obviously, other things like make sure you drink enough water, sleeping well, stress management. So we have a psychologist working our service, so she is trying to do the stress part, but exercise is the most effective one. And the problem with migraine patients quite often is they say, I can't do exercise because it gives me a headache. This can be tricky because there's a difference between you have no headache at all and you exercise and you get a headache, then you need a scan. If you have already migraine, mild, 2 out of 10, and then you exercise and the headache gets worse, that is quite common. But if you are completely pain-free and every time you're exercising, it gives you a headache, then you possibly should get a scan. But exercise by far, and when I talk exercise, I don't mean like weightlifting or running marathon, going for a walk 5 times a week for half an hour, something like this in the fresh air. That's the best lifestyle advice.
Okay, great. That's great. Thank you. Mentioning the scans, it's been asked whether or not an MRI scan can give any indications to what type of migraine a person has.
What type of migraine? Yes. Okay, there are different indications. In the UK, NICE will say when patients have typical migraine, you don't need a scan. When I learned in Germany, we were told you're not allowed to diagnose a migraine without having a normal scan. There are different things in different parts of the world. If somebody has migraine with aura, I always do a scan. Somebody with visual disturbance, with double vision, pins and needles, tingling, I always do a scan. When somebody has a headache, there are some red flags called the Snoop criteria. You can look them up, Snoop 10 criteria. For example, somebody tells you I'm waking up with a headache, I would do a scan. Somebody said my headache is getting worse when I'm standing up or lying down or coughing or sneezing, you do a scan. So these are red flags. And so on these patients, I would do a scan or further investigation, whatever I think is needed.
Okay, so a bit different then really, isn't it, Germany to the UK for that?
Yeah, different parts of different guidelines, unfortunately.
Yeah, absolutely. Someone said that they've been taking Dolovent, which is a supplement combination of magnesium, riboflavin, and coenzyme Q10 for a couple of years. They said they're not sure whether it's had any effect, as they're also on a combination of other medications, and should they keep taking it, or is it designed to only be used for a few months? I guess that's also just kind of asking how long can you use supplements for, and is there any time limit on that as well?
I don't think magnesium is a time. My understanding is when you take too much magnesium and your body has enough magnesium, you just lose it over your bowels and you're getting diarrhea. So you will realize you take too much. So your body will regulate your magnesium intake. But I would have patients who are concerned about, I would take a blood sample and check the magnesium level to make sure it's okay. But usually these kind of medications, I think you can take them a long time. But if you're concerned, go to your doctor, get your blood checked to make your magnesium level is not too high.
Okay, great. And is there much evidence to show the effectiveness of the supplements like the magnesium and the vitamin B2?
Yeah, I don't have it in my head. There is some, we give magnesium, but we also give a lot of riboflavin, there's vitamin B. And there is some evidence, but the evidence not as strong than for some of the other migraine preventers, but obviously they're much better tolerated and has much less side effect. So we give them a lot, and we quite often add them to migraine preventer. We do this. The problem is that quite often these medications, GPs don't prescribe them, and the patient have to buy them themselves. That's sometimes, but there is evidence there, yes.
Okay, lovely. Thank you. This is quite an interesting one, actually. So someone's asked whether or not the type of drug prescribed can affect the nature of the migraine that they experience. So they had migraine with aura, but they now have vestibular migraine, having moved from amitriptyline to candesartan.
So they had migraine with aura, has now vestibular migraine, you said?
Yeah, so they changed the medication and they went from having migraine with aura to having vestibular migraine.
Okay. So we have in our team, we have one physio who is specialized in vestibular migraine. So she works with ENT together as well. So we are, because sometimes it's hard to differentiate what is vestibular migraine and what is vertigo. So I don't know why it was changed, the medication. So vestibular migraine, we treat exactly the same like migraine. That could be amitriptyline, could be candesartan, could be propranolol. So we don't make a difference regarding the medication. Now, when somebody have vestibular symptoms like dizziness, you always have to think also with other things. That's the reason I told you need an MRI scan. On these patients, we do scans. You want to make sure the blood flow is normal in the back of the head and the cerebellum. So for that reason, we normally would do a scan on these patients to make sure we don't miss something else. But this vestibular migraine is possibly really underdiagnosed, but we treat it the same way like migraine.
Okay, lovely. Thank you. This is actually an interesting question as well, considering obviously the situation in Belfast for medications. If a person failed on the preventives, they can't access the Botox or the monoclonal antibodies because they're not funded, but they have more than 8 headaches in a month. What do they do about that? What other medication option is there, and what can they do in a position when there is no funding for further treatments?
That is my daily problem. I'm working,
yeah.
so because I work in Belfast, but I see patients from all over Northern Ireland, and you look at the postcode, and unfortunately, you treat patients different if they're living in the Belfast Trust area or if they're living outside the Belfast Trust. It's very unsatisfactory for myself and for the patient. So if somebody, well, I think they should put pressure on the board, you know, they should kind of make people aware of the situation. But if you failed on, as I told, there are many more migraine preventers. So when you have failed 3 or 4 or 5 migraine preventers, there are other ones to try. But the possibility that they are working is getting possibly lower and lower and lower, the more you are trying, you know. So I do think when the situation in Northern Ireland hopefully will change over the next while, I would guess. There should be funding for all patients for Botox and monoclonal antibodies.
Yeah. Yeah, hopefully it does change in the future. Fingers crossed for that. So.
Yeah, I don't know how it is in the rest of the UK. Only can talk about Northern Ireland. I don't know if to these drugs in the rest of the UK.
Yeah, there are some areas in the UK that are still struggling with funding for it. Surprisingly, even though it's been out for 3 years, so it's a bit of a difficulty with those treatments. Someone else has just asked as well, just about, so they're currently taking amitriptyline 10 milligrams and prochlorperazine. They have obviously the triptan medications as well, but they are noticing weight gain with their maintenance treatment plan. What would the alternatives be to try and prevent the weight gain?
Amitriptyline can give you weight gain. If that's a problem, when it's worked, when you think, well, it might work, otherwise I have no contraindication. What I sometimes do, I change this patient to nortriptyline. It is similar, the side effects are slightly different, so you can swap it from amitriptyline 10 to nortriptyline 10. It's a bit of trying things out and see if it works or not. And that can be increased then up to, also up to 70, 80 milligrams if needed.
Okay, perfect. Right, lovely. So the nortriptyline doesn't have the same weight gain side effect as the amitriptyline?
Everyone is different. Side effect can be different between amitriptyline and nortriptyline. Every patient is different. Some patients take amitriptyline and don't gain weight. So the only way to find out is really to try it. But I tried quite often that I try medication swap with triptans. You change between the different triptans because they have slightly different side effects. If one doesn't work or you get side effects, you might want to try a different one.
Yeah.
If it helps, we don't know, but you should try.
Yeah. Okay. Perfect. That makes perfect sense. And also, just with medication overuse headache, is it necessary to always completely stop the pain medications, or can you do like a reduction in how much you're taking?
Yeah, so medication overuse headache is important that you don't take the medication every day. So some patients tell me I only take 1 paracetamol tablet every morning. I would prefer they are taking 8 paracetamol tablets a day, but only on 10 days per month. So you need days where you don't take anything at all. So it doesn't make sense to take a low dose every day. We prefer to take a full dose on some days. So you ideally can reduce it. I normally tell patients try to stop it completely and be off the medication maybe for 2 weeks and then see what the headache is doing. And if you still need something, then you can restart, but really controlled on the day you need it. And there are different ways to look at this because I know there are different studies done. Some studies where they decided to stop cocodamol completely, suddenly, and other studies where they told patients, okay, you can take about only 10 days per month.
Yeah.
And patients who stopped it completely found it easier because it's like with smoking. When you say, I stop smoking completely, or I'm only smoking 3 cigarettes per day, then you think, oh, should I take it now or should I wait for later? You have to think about it. Well, if you stop it suddenly, it's actually easier to do that. That's what some patients felt.
Yeah, stopping suddenly is easier than doing a reduction in the long run, really, for that. I know we're coming a bit short on time, but we have had some queries just about menopause and HRT of migraines. So many people didn't really have the menstrual migraine, but the migraine manifested when they hit the perimenopause and the menopause, and just whether HRT can also be a trigger for migraine during menopause as well as being used as a treatment.
Yes, I suppose it is. I'm not the expert there, but we do know that hormone fluctuation in general is a trigger. The fluctuation of the estrogen level. It doesn't really make it important if the level is high or low, but you don't want to get it up and down. So for that reason, menopause, I could imagine, is definitely a trigger. HRT, I'm not sure about this. But menopause, I can imagine. Hopefully after menopause, the headache will settle down quite often.
Yeah, okay, lovely. I think that's probably all we've got time for today. What I would suggest, if anyone's question hasn't been answered, if you send that over to the helpline, we can get that answered for you and get back to you as soon as we can. And I'll just pass back over to Debbie.
Thanks, Steph, and thanks, Thomas. Thank you, everybody, so much for joining. I hope that was a really interesting hour for you. Apologies again if we didn't answer your question, but maybe we have by answering somebody else's. So as Steph says, please feel free to call the helpline or email your question into us. I hope you all have a good rest of your day, and we will see you soon. Thank you.